Welcome once again to Free Associations for the Boston somebody joke. Welcome once again to Free Associations for the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who is as confused by the latest health study as I am by movie theaters. Why do they still exist?
Oh,
does
so you can eat popcorn?
Still go to them?
Absolutely, so you can buy popcorn, which I do without seeing the movies at several movie theaters in my neighborhood.
Yeah. So do you pretend like you're going to buy a ticket?
No, not at all. They know me by
in?
now. They just let me right in.
Hey, popcorn guy.
Popcorn man.
Do you go for buttered and salted or sweet?
No, it's absolutely pure. It's got to be pure.
Unadulterated?
No butter, nothing.
Wow, a purist.
Wait, how
it's really
can you
weird.
get
The looks I get when I'm walking down the street with a huge tub of popcorn are really pretty remarkable.
How can you get pure, unadulterated, unsalted, unbuttered popcorn at a movie theater?
No, you get a little salt, but you just don't ask for
butter.
butter.
That doesn't exist.
Yeah, it does.
No.
Yeah,
There's somebody.
In fact, in the movie theater in your hometown in Arlington, it has some of the best popcorn around. I go there on a regular basis on the way home.
For anyone who doesn't know, Don is a popcorn connoisseur.
Addict.
That would be the fair term. Addict would be the fair term. All right. Well, I am Matt Fox from the Departments of Epidemiology and Global Health, and I am joined by the dynamic duo in Boston of Don Thea and Chris Gill.
Hello.
Hi.
And they are in Boston at the Godly Studio. I am now. This I think we can finally say will be my last episode here in London. And before I go, I want to point something out, which is I have been doing this podcast from my bedroom in London because I don't have a place to go to like you guys have. And we live near Hyde Park in London. And do you know about the Hyde Park parakeets?
No.
So I don't know the history of them, but you can go to a spot in Hyde Park, and there are a troop of parakeets that fly around.
Gaggle?
A gaggle, I don't know what you call
exaltation?
them.
Maybe a penumbra.
A whole
lot
of parakeets, and you can feed them. So if you hold out food, they will come fly down onto your hands, and they will eat from your hands. Now, we live about, I would say, 2-3 city blocks away from Hyde Park. And we live across the street from a park, kind of like one of the parks that are in between a square like you see in Hugh Grant movies. Mm-hmm. And so we have one of those that I'm staring at. And while I'm recording the podcast, sometimes the parakeets will fly into our park and hang out. And I get to watch them while you guys are in a cold, boring studio.
Windowless.
That makes me feel terrible.
Windowless.
But I know one thing I can do to cheer myself up, which is to go into the Population Health Exchange website. That always picks me up.
Parakeets?
There's a lot about parakeets, in fact, and budgies.
What else is there?
Parrots
and
macaws.
Any population health learning tools and programs?
I forget. I wasn't really paying attention to that, but I suspect there might be.
Well, anyway. If you are actually listening to this and you really like the parakeets, or you've ever fed the parakeets in London, the best way to let us know that would be to go onto iTunes and give us a 5-star rating, and then fill out a comment which says, "I am giving you this 5-star rating because I really like the parakeets in London." That would really help us out.
I thought iTunes is no longer going to exist.
Yeah, it's true. But they're going to come up with something even better that has...
Okay, so I have no idea what you're talking about.
iTunes, they're getting rid of it.
You're kidding, right?
Apple announced they're getting rid of iTunes.
They are.
Why?
They're disassembling it.
Yeah, because they want to drive everyone onto Apple Music and have them stream from wherever they are. Convenient places like rural Zambia, where it's not as easy to get my streaming Apple Music. Are you listening, Tim Cook?
That was remarkably specific, Chris. All right, well, now on to the show. So today in our first segment, which is our Journal Club segment, we're going to look at a study that assessed the impact of medical scribes on the productivity of doctors. Then in our second part of the podcast, which is our deep dive, we will talk about the Journal of No Big Deal Results. And then in our Amazing and Amusing, we'll get into some things that make us laugh out loud, or Chris will tell us why we should stop fearing and learn to love naked mole rats.
Anxiety is totally unwarranted.
Totally. So, all right, segment 1. So this week we're going to look at an article on the use of medical scribes to improve doctors' output. So this was published in the BMJ, which, by the way, I didn't realize is called now the BMJ.
Right.
Yeah. I thought BMJ was an abbreviation for the British Medical Journal, which it used to be, but it is now the actual official name of the journal.
Right. It's a lengthenization of BMJ.
So the study was entitled "The Impact of Scribes on Emergency
That just slipped
Medicines."
past you there, Matt.
What's that?
The lengthenization of the BMJ.
That's a perfectly cromulent word.
Oliver Cromulent.
Have you ever seen the Simpsons episode where they're all obsessed with the word embiggens because the hero of the town embiggens the every man, and Lisa says embiggens is not a word. The teacher says, "Oh, stop it, Lisa. It's a perfectly cromulent word." And now if you look up the word cromulent on the internet, it will say a made-up word made to sound real.
I like that.
There you go. Anyway, impact of scribes on emergency medicine's doctors' productivity and patient throughput. A multi-center randomized trial by Catherine Walker from the emergency department at Cabrini Hospital in Malvern, Australia. Now, I'm not going to pretend that this one got overwhelming number of headlines, but it did get some. So the Brisbane Times says, could this simple idea be the key to cutting hospital wait times? Newsmax says the simple way to improve emergency care, and Health Day says medical scribes could improve ER healthcare. So Don, walk us through this study. What do they do, and how do they figure out that scribes are apparently good for a...
So a scribe is a trained individual who assumes most of the clerical tasks of that a physician would ordinarily be doing during a doctor-patient encounter. And as the burden of reporting and the burden of electronic medical records has increased over the course of the last several decades, there's been an outcry from physicians that they're spending all their time doing this clerical work and not enough time sort of with that patient-doctor interaction. So they've been around for a little bit of time, and there have been a number of studies which seem to go both ways in terms of there being a useful adjunct to what a doctor does. And so what this group wanted to do was to sort of take another look at that and do it in a kind of a structured non-blinded RCT way, where they had a handful of scribes and they would randomly allocate them to physicians in 5 emergency departments in hospitals in Victoria State in Australia. And their outcome was whether it increased the productivity of the physician, whether it decreased the amount of time that the patient was in the emergency department, and whether it was cost effective when you take into consideration the cost of training of these scribes and the salary paid to them in comparison to the salaries paid by the physicians. So, as I mentioned, it was 5 ERs in Victoria State. They were public, they were Medicare, they were pediatric, it was private, tertiary. So they really tried to get an array of different settings, and there were differing physician roles. In the Australian setting, physicians oftentimes are sort of the main triage. So somebody comes into the ED with a problem, and they talk to the triage doctor, and then he allocates whether they need to be seen immediately or they can be seen less urgently. So they had the kinds of things that these scribes would do that were previously done by, or would be done by the physicians in settings where they were not assigned a scribe, were things like in-room documentation of the history, the physical, the medical plan. They wouldn't be making a medical plan or a diagnosis or a disposition. They would be just recording it from what the physician said. There would be primary care letters, adding clinical details to requests, calling in radiology staff. So all of the sort of tasks that don't require a level of knowledge about medicine that is required by the physician. So they were randomly allocated by shift. The scribes would use a computer for note-taking while they were sitting in with this patient encounter. And on occasion, the patient said to the physician that they were uncomfortable having a third person in the room. Although that happened very rarely, the overwhelming majority of the scribes were there. The scribes were half medical students and half pre-med students. So they actually had a little bit of pre-medical and minor medical training prior to this. As I mentioned, the primary outcome was the difference in productivity, or the number of patients that were seen per unit of time, between physicians who had a patient encounter that was what they call scribed versus non-scribed. And the secondary outcomes were the door-to-doctor time, or the time between when the patient walked in the door and they actually encountered a physician, the length of the ED stay, and then something which I didn't understand, which was regional physicians' productivity. I guess that must mean just the productivity according to what different setting, i.e. different doctor, different task that the doctor was performing, and whether it was a pediatric emergency room or a private or public. They also looked at the safety, whether there were any errors, medical errors that occurred during the course of this encounter that could be ascribed to the scribe.
That was
Bitch too.
that's Chris's job to make the puns.
They also looked at cost effectiveness. So they determined that they needed 1,000 shifts. So they had 100 scribed and 100 non-scribed per each of the 5 hospitals for 1,000, and they had 88 physicians that were participating, and there were 589 scribe intervals or sessions, and 3,263 non-scribed sessions, so far in excess non-scribed sessions versus scribe sessions. And there were about 5,000 patient encounters that were scribed and about 23,000 patient encounters that were unscribed. And the results were basically that the scribes did increase the productivity mildly. It went from 1.13 patients seen and processed per hour in an unscribed scenario versus 1.31 patients per hour. There was no difference in the door-to-doctor time, and the length of stay for the patients was approximately 19 minutes shorter if there was a scribe that was involved. And there were 16 events, sort of adverse events with scribes, which they calculated to be about 1 in 300 per patient encounter. And then the cost-benefit analysis indicated that there was a savings overall when you took into consideration the time and the salaries and the training costs. That's basically it.
So, Chris, I'm going to ask you the usual question, which is, what did you think of the study? But the other question that I'm going to ask you is, I want you to make the case for why this study was important enough for us to talk about. Because you were the one who said that you like this study, and we all know that choosing a study for this program means that they are going to get the free associations bump. We all know that downloads go way up after we talk about it. Actually, if somebody could do that study, there's a way to estimate a null effect. I think that would be really interesting.
Buy scribe stock before we go live on this.
Why was this one? Did you think this one was an important one for us to talk about? Because I think to many of our listeners, this might sort of seem like not an obvious one.
Okay, well, yeah. The easiest answer of all is that my wife is a pediatrician. So she is in this world of electronic medical records. The particular EMR that they use is this thing called Epic, which actually I used as a resident when I was 20 years ago. But Epic has gotten super complicated, and it takes so much of her time just to sort of click boxes and do little administrative tasks, and it, the response, because she is a very conscientious doctor, is that she does not chart while she's in the room, and the consequence is that she comes home every single night and charts for like 3 hours, and none of that is built. So like the EMR has in no ways sped up the process of patient care delivery. What it has done is increase the administrative burden upon the physicians, and so this movement towards the scribe is a rational attempt to counter that trend, because I think this actually has become somewhat of a crisis in healthcare, in the way that healthcare is delivered. So I thought that this was a timely study. I will say that I thought it was interesting, but I really wish it had gone a little bit further, because I think they missed a couple things. That they measured some things that are practical, like time, like patient throughput through the ER. But that one depresses me, because the point of this is not really to say how fast can we drive the doctors to see as many patients as possible in a shorter period of time. That is antithetical, in fact, to my vision of how good medical care should be provided. So what I would have loved them to do is to look at other things like, what is the impact of the scribe on the doctor's quality of life? After the ER doctor shifts, how many hours do they sit there dictating their notes or putting their notes into the AMR?
And they specifically left that out of this analysis.
And they left that out of this analysis because I would love to know, because that time is not compensated. And I would love to know, did it in fact save them 2 hours a day of sitting there after their work is officially done, yet still working? That would be great. I would like to know, does it actually impact the quality of care? Because you think that the total amount of time that they recorded that was spent per patient encounter, I guess the throughput, right, increased. So the total amount of time per patient went down slightly. Okay, so, but is that a good thing or is that a bad thing? I mean, it seems like a more efficient thing from the hospital administrator's perspective. But what I would really like to know is like how much of the time when they're sitting in the room are they focused on their patient as opposed to clicking boxes on a computer and like not making eye contact and sort of, because from a patient's perspective, when your provider is sitting there typing away on a machine and looking away from you, as a patient, you don't feel the love, You're sort of like, hey, I'm over here. Stop fiddling with that device. Pay attention to me. I would have loved to know, how did the patients feel about it? It didn't change their perception of the quality of care they were receiving. So there was all sorts of like tantalizing but totally unanswered questions. And I found it a little bit depressing, even though I liked the idea and I liked the study and I thought they did it well. I found it a little bit depressing that they focused on throughput as being like the win. And to me, that's like the bottom line for the bean counters, but it's not really about medicine.
Yeah,
that was my takeaway on this.
I found myself just thinking, like, did this study need to be done? Is it in any way surprising to learn that if you give an emergency medicine doctor a scribe, they will be able to spend less time with the patients if that is your goal, but that should reduce patient time? It doesn't seem to me that was really something that we needed to figure out so much as, and I do accept this part, which is if we believe that it is going to improve patient quality of care, maybe quality of life for the physician, maybe reduce my time that I have to spend in the doctor's office or in the emergency room, and we think those are good things, it comes down to cost. And it's primarily about whether or not this is affordable and cost-effective. And they did do a cost-effective analysis, but I have to admit I found that cost-effective analysis fairly, not unconvincing, but it seemed, as they describe it, it was a post hoc analysis. So it wasn't the focus of what they were doing. They did this after the fact, and it came
at one site only.
At a post hoc analysis, and I was a little surprised by that because it seems to me that we largely knew that maybe we didn't know the amount of time that it was going to reduce the interactions, but I think we knew that it was going to reduce the interactions.
Right. There were other couple sort of downsides that they hinted at, but didn't really explore in much depth. One, which is, I have to give credit, was raised by my wife, which is that in her experience, when she has medical students in the room, that her patients are often reluctant to sort of be quite as forthcoming about the real reasons why they're there in the doctor's office, because they're embarrassed and they don't want a third person like in the room hearing what is said. And so she's very concerned that the scribes will create that sort of barrier to open discourse. Another thing that she mentioned to me, is based on experiences from her colleagues in internal medicine who already use scribes, is that the turnover of scribes is incredibly high. You mentioned at the beginning that the scribes here were pre-med students and medical students. Well, medical students get super busy and disappear and go off and become clerkships and become doctors, and they do not remain scribes for long. Mm-hmm. Pre-med students, their one goal in life is to no longer be a pre-med student, but to be a medical student. So they're not going to stay for long. So even though they have a modicum of medical training, they are not a stable population from a work perspective. So the effect is that you're always hiring and rehiring and retraining scribes. And so it's actually a difficult model to implement long term. I think those are my main concerns that are not addressed here.
I think the two things that I found in this paper that sort of go to the validity of the findings were that they offered training for the docs, but none of the docs accepted training.
That was going to be one of my last words.
Right.
How surprised were you by that?
I was not at all surprised.
Not at all surprised.
Not at all.
They were like, you got to be kidding me.
So they just like walked in the room cold, and they didn't really know how to probably optimally use these particular scribes. And then the other thing was the randomization. And I think that, to sort of randomize it so that you don't develop, so there's not a relationship developed between the doctor and the scribe. And I think that there probably are, really good relationships that are really efficient and not so good relationships that are far less efficient. And I think that what you would want to do would be to really assess a good doctor-scribe relationship, because that obviously would be optimal. And probably, if in fact you could find scribes that would hang around for a while, that would be the way that it would evolve and fall out, which would be that when there's a good working relationship, it would be a sort of a self-fulfilling prophecy.
Mm-hmm.
So I want to use this to make a what may seem like an obscure epidemiology point that I know you guys are going to roll your eyes about, but I think can potentially matter, which would be totally
obvious on a podcast.
I think that this may suffer from what we refer to as the consistency problem, or the multiple versions of treatment problem, which is that this isn't one intervention.
Mm-hmm.
When you think about a drug, the drug is pretty much the same. You give it to everybody, and it's going to interact with the body in more or less the same way. But so we can think of it as the same treatment that everybody is getting. Whereas anything that's behavioral in nature, or that is dependent on the skill of the person practicing, you're not really your effect that you're going to observe is going to be entirely dependent on that skill, and therefore you're not going to be able to translate that into anything that comes across populations. Now, they had, I think, how many? 12 scribes. Mm-hmm. So to begin with, you already have a lot of variability. And as Don, as you point out, it's not just scribe, it's scribe doctor chemistry or interaction ability. Yeah. Ability to work together that's going to determine how effective this, and then it's the ability of the doctor to utilize that person. So I don't know that we learn. I don't know that a 19-minute reduction that was found in this study is going to translate into a 19-minute reduction in another study. You could implement this; it could be a total dud in some populations. You get much better, larger effects in a third population. So I think this one is entirely dependent on how it's implemented.
Mm-hmm. Another really important thing that was danced around a little bit in the study in terms of the adverse events that they recorded, it would be really important to understand at a much larger scale what is the aggregate impact in terms of patient safety, or the accuracy of medical diagnosis, or the precision of treatments issued of having a scribe. Because if you read through the list of adverse events that occurred, it seems to me that there's sort of an equal number of instances where the doctor made a mistake and the scribe spotted it, right, versus the scribe made a mistake and the doctor spotted it. Right. One has to wonder about, what about the times when neither of them noted the mistake, which would then not end up as an adverse event, perhaps, because no one knew it happened. Right. So, that sort of exploring the boundaries of the risk-benefit ratio more precisely would seem to be very important.
Mm-hmm.
Yeah. So another thing, so when you think about, the usual stuff that we critique studies for, there was very, very little baseline information on these populations to be able to compare whether the periods during which the scribes were used and the periods which the scribes were not used were in fact comparable. And I would think, I don't totally understand exactly what these encounters were, but I would think there could be a lot of variability in how much time you spend with a patient, depending on what the condition is that they're coming in for. And, were those balanced across arms? Well, there was a lot more unscribed time than scribe time, just because of the way that they did the randomization. But we don't have a lot of information to tell us whether or not we should believe that these are good, balanced populations, which kind of surprised me.
Mm-hmm. Yeah, me too.
So jury's a little bit out. We liked the paper, but
could be more depth.
More questions to be answered, and yeah.
Yeah, agreed. And when I say the jury's out, I mean, I don't have a huge problem with what they did. I mean, I I have some, but I mean, I generally buy the idea that in their population, this worked and was effective. It's just, I didn't feel like it answered the questions that probably you'd want to have answered.
Yeah, I mean, I think, Chris, your point about did it really affect the quality? Not necessarily, well, the quality of the interaction between the patient and the doctor, that's one thing, but also did it compromise the bottom line, which is, a good interaction between the doctor and the patient, which results in a firm diagnosis and a reasonable treatment plan, and we have no idea whether it has that effect. So there was a difference, but does it really matter? What is the impact?
Yeah, well, the hospital administrators will be happy that their ER docs can see more patients per hour.
Yeah,
exactly.
But that, from a patient's perspective, doesn't necessarily make me feel particularly reassured.
Or necessarily from a doctor's perspective.
And the doctors don't just want to be driven.
Right.
That's not a plus necessarily. It's
interesting. All right, any last comments before I take the last word?
Nope. Go ahead.
Okay, so a couple of things that popped out to me on this one. 2 physicians withdrew mid-study as they did not find scribes useful. I thought that was just an interesting fact. Second of all, and I don't know if this is a BMJ thing. I don't think it necessarily is because I looked at some other ones, but I noticed that the limitations and strengths section was the second paragraph of the discussion, which does not fit the mold that I always say, where the discussion, the limitations are always the second to last paragraph. So that you don't have to, you have to already have drawn your conclusions, but you don't end on a downer. So, and last but not least, did you notice that one of the co-authors was Adam West?
No, really? Of Batman?
Batman. Robin, right?
I'm going to assume it's a different Adam West.
Oh, man.
All right. Let's move on to our second segment where we want to get into an article that was published in Vox by Kelsey Piper, which announced a new journal. It's a journal in the economics field, so it's not something that we may necessarily have come across. And it is called the Series of Unsurprising Results in Economics, otherwise abbreviated to SURE. The idea of the journal is aimed at fighting publication bias. So the first paper that they published, as an example, was by Nick Huntington Klein and Andrew M. Gill of California State University, which looked at whether informing students about the benefits of taking more credit hours to improve their odds of graduating would motivate them to take more classes and finish school sooner. And the answer is no, it does not. And the idea here is that you have a journal that is dedicated to, now, so this is a little unclear to me. Is it to publishing null results or unsurprising results? The title of the journal is Unsurprising, and I don't know that null findings are always necessarily unsurprising, and I don't know that non-null findings are always a surprise.
Right.
So it isn't clear to me exactly what the focus here is, but the general idea is we're trying to combat publication bias. The idea that if we have something that is not particularly interesting or is a null finding, that we have the file drawer problem. These studies get stuck into the file drawer. They never get published. And then the studies, the odd study that does find a significant result for that particular exposure outcome relationship is the one that does get published. And we end up thinking things that are interesting findings are real findings, when in fact, if we had published the totality of the literature, we would know that these aren't real associations or real effects, I should say.
The problem is that they're going to need a lot of journals, or this journal is going to have to do a lot of publications because, as we've mentioned many times on the pod, and Professor Enides has mentioned in his why most publications or published findings are false, the null findings exceed the true findings by a significant margin. So we might need like 10 versions of this journal in medical sciences to sort of really start to even come close to balancing out the true array of null results that are out there, and null and dull results, and a lot of peer reviewers too. Yeah.
So the question is this a good idea, or is this really just a gimmick? They've named it the Series of Unsurprising Results in Economics, sure, right? So there's clearly a bit of humor going on here, and so is this really just a joke?
I don't think it's sustainable.
Why not?
Because in part because of what Chris said, and I think that I don't know what the model would be to really have the entire system support the review and publication the review and acceptance of high quality, though null resulting studies could be that would be able to keep an effort like this alive, especially at the numbers that Chris alludes to. I think it's it's an ideal aspiration that I don't think is achievable.
Mm-hmm. I wish there was a different way of doing this, like that it started with the grant, that there's a commitment by NIH or Gates or whoever is giving you the money that you will publish your results irrespective of the results of that trial, and that there be some platform established to do that. And it could be that this platform is quite dull, like the public, not the public library of assignments, but what's the one they call for the National Library of Medicine? PubMed Central, right? So, but again, how would you do that without a peer review process? That is
you
the
have to
trick
have
here.
Yeah.
I don't quite see it.
You have to assure that the quality of the science, not necessarily just the results.
Yeah.
Agree. Just because something is null doesn't mean that it doesn't require rigorous peer review. I mean, we could so one of the problems that I have with this is the fact that they called it series of unsurprising results. Unsurprising implies we really already knew this, and we just needed confirmation. Now, I think they were trying to get more at just not like headline grabbing type results. But where's the line between headline grabbing and null, which I think is what we're really trying to get at, is that people are not publishing things that are null. And my problem with that is null findings are important findings, especially when they are precise null findings. So, if you can do the study, I feel like I've said this a million times, but if you can do the study that convincingly demonstrates that eating ice cream doesn't cause cancer, that is incredibly useful information for ice cream eaters.
I'd like to know. So I want that study published in the New England Journal of Medicine. I want that null finding published. So if we're talking about null findings, I think that those should be, again, when well done, should be published in the same journals where the non-null findings are published. Because otherwise no one's ever going to read them. But I guess you find them in lit searches, if you're doing a systematic
review. If on the other hand, we're talking about really a boring study that, no one ever had any interest in the question in the first place, then who cares?
Right.
One of the other things that we've talked about on these podcasts through the long series of episodes that we've done is the reproducibility crisis. And I think that the comment you made really resonated with me, Matt, where you said, do we already know this? And if we already know this, it implies that this is not necessarily a contribution to the literature. But at some point, we do have to have some confirmation. We have to have observations or results confirmed with additional studies that support it, and you can't, it can't just be a one-off. It has to be, there have to be several looks at from different directions in terms of whether it's a real finding.
Mm-hmm. Yeah. Mm-hmm. So I just looked at their website, and they say Sure benefits writers by providing an outlet for interesting, high quality, but risky in terms of uncertain results research projects. So interesting seems to contradict unsurprising. I know it's not a direct contradiction, but to me, that sounds like a contradiction. And so I'm just unclear on what this effort is intended to do and why we wouldn't be publishing those high risk studies where we weren't sure of the outcome in the same journals where
It also fails to address the other half of publication bias, which is not just the journals are, not enthusiastic about accepting dull papers, which have, unsurprising or null results, but that investigators are demotivated to submit those articles because they are unsurprising and boring results because their hypothesis was not sustained. In fact, I think investigators have an inherent conflict of interest when their pet theory has been disproven by their own experiment, and they may not even want to mention that. So let's just sweep that one under. So of all the sort of attempts or strategies that we have discussed on the pod to combat publication bias, the one that I think still resonates with me most strongly is this contract between the investigators and the journal based on the protocol and the specific aims and the SAP, the analysis plan that is established before they do the experiment, and that the journal will commit to publishing the results regardless of the experiment. But it also holds the investigators accountable for fulfilling their half of the bargain, that they will also submit the paper and not just say, oh, it was a negative result, blah, let's move on.
Yeah.
So I agree with everything you just said there, Chris, but that's a case where, we want to get this result out there. We did the experiment because we thought it was an interesting hypothesis, and we want to be able to publish it even if it turns out to be null. But that's not uninteresting. That's just null. I think, if you read the New England Journal of Medicine, they definitely published null findings of, large randomized trials that didn't find an effect of the thing that we thought might work. So big drug that, turns out to be ineffective. So it isn't that you can't publish null findings if they're really interesting. This is meant to be, I think, for things that are less interesting. And I'm just not clear on what the incentive is to be doing uninteresting research, let alone publishing it.
Mm-hmm. Let me propose the obverse of this. I don't know if you guys notice this.
Obverse?
Yeah.
Is that a word?
Yeah, that's a word. I don't know if you guys followed this, but in the Washington Post a couple of days ago, there was a major story about Pfizer and about how Pfizer had done an internal study, retrospective analysis of a whole lot of individual cases where they looked at the development of Alzheimer's disease. And they looked at sounds like it pretty much was a fishing expedition, but they looked at a whole bunch of potential predictors for Alzheimer's disease. And they found that prior use of Enbrel, which is one of their drugs.
This is the TNF blocker.
The TNF blocker. Prior use of Enbrel conferred a 67% decrease in the likelihood of developing Alzheimer's disease. And they very specifically chose not to publish that. And that was dug up by the Washington Post. And they gave them a huge amount of grief about this because they implied that if you did the study and if it was done well, why wouldn't you publish that? And then there was a whole sort of deconstruction of what their motivations might have been because Enbrel's coming off patent and they didn't want to sort of tip their hand and somebody else might look at this class of drugs because it might, hit the mother lode for Alzheimer's, which should be an incredibly big market. But what the representatives from Pfizer said was that we looked at it, we thought it was interesting, but we felt like it did not stand up to our internal scientific scrutiny, and we chose not to publish it in part because we felt that the science wasn't rigorous enough. And the comments were by a lot of people, well, that's not enough. You should publish it, put it all out there, and let the community decide. Mm-hmm. So it really is a situation which is kind of turned what we just talked about on its head. And I haven't heard about something like that happening before in that setting with the private sector and those potential motivations. And I think it raises a whole bunch of really interesting questions. And I was going to suggest it as a pod, but apparently Pfizer won't release the data, so we can't assess it.
So that's a really interesting one. I mean, so obviously that wouldn't be solved by this particular journal, but it's a really interesting case because do we want? So we have reason to not necessarily trust the motivations of a drug company, but let's say their motivations were legitimate. That do we really want, bad science getting published? Or do we feel like, well, if it was done to the best of their abilities, even if it couldn't say, control, I'm assuming these were observational studies. This wasn't a trial.
Yeah, I think it was a retrospective analysis of sort of panel data.
Right, so it's sort of hypothesis generating. Well, then maybe it should be out there, and so it's a tough one. Obviously, they have incentives that are not aligned with publishing. Why
not put it all out there? Why not be transparent? Why not let the reader decide whether this is a good study or a crappy study?
Yeah, well, who's the reader? I mean, if we're talking about the scientific community, then
I
agree with you. But that we know that's going to end up in the news with headlines that say. In fact, I would actually bet, based on the headlines that were in the Washington Post, people are going to believe that this works.
Mm-hmm. Mm-hmm. Well, I mean, that's where peer review comes in. In part. I thought it was interesting because it sounded like it was an internal struggle within Pfizer. Yeah. It was the immunology team that said, these are really interesting findings. We ought to publish this. And it was other teams not in that realm that were saying, no, let's not. Anyway,
now, what if their justification was, we're not gonna publish this because we think this is hypothesis generating, and what we're going to do is we're actually going to run a trial to try and answer this question because it would be another way we could market this drug.
Well, according to the article, they specifically rejected that possibility because they said the science isn't strong enough to support the expense of a trial on this. But if it's real, it's a pretty profound effect, a 2/3 reduction in Alzheimer's disease. But I think that we have pointed out the difficulty in doing sort of long-term prospective or observational studies of Alzheimer's disease. It's just really, really, really difficult.
Yeah. So fair enough. I don't think we're going to answer this one, but one last question back on the topic of this journal. Like I went and looked this up because I was concerned that this was actually a joke, that I have been known to fall for these things before. So I did look it up. At least I think it's legit. But then the question becomes: is the title of the journal helpful in us taking it seriously, or do you think it actually hurts in that it's sort of gimmicky?
I think it undermines the seriousness of their effort, because it's a serious issue.
Yeah, and I think if you're really trying to do this, I think you would go with something a little bit more, I don't know,
Journal of Unbiased Science. How about that?
I suppose you'd have to make sure you didn't have anything that made it sound like it was a predatory journal as well.
Right.
Yeah. So finally, let's move into our last segment, which is our amazing and amusing. Don, I'm gonna let you go first this time, since I made you go last time.
Oh boy. All right. So I have an article that was published in International Society for Microbial Ecology by Isabel Reich, Janetta Dorta, and others from Spain.
Okay.
And essentially what they did is they quantified the level, the burden of viruses that come from the atmosphere that are raining down on us at all times.
Wow.
And this is known viruses. And there's a project that's being supported by USAID, which is intended to look at all of the estimated 1.7 million unknown potentially pathogenic viruses. So these guys just looked at the viruses that are known, and one might only imagine how many viruses there are that weren't measured. So basically what they did is they took these virus traps and they put them at a very high level in the Sierra Madre Mountains in Spain. And they did a series of runs of this, and they determined that there are over 800 million viruses that are deposited daily on every square meter of these areas high up in the Sierra Madre Mountains. And what was
that number?
800 million viruses per square meter are raining down on us every day.
And it could be worse at the lowlands, right?
Well, apparently the ratio of viruses to bacteria is higher the lower you go, only because bacteria become more numerous because they're rarer at altitude. But they also found that these viruses are sort of swept up from the Sahara and from sort of local surroundings, and they're kind of attached to the dust that gets elevated into the upper atmosphere, go across the Atlantic, and then rain down on the United States. So I just thought that number was far in excess of what I thought was raining down on top of my head as I'm walking the streets. And
that is astounding. So we are, in other words, we are constantly being bombarded,
rained upon by 800 million viruses.
And inhaling all of that stuff.
Right.
Constantly.
Right.
And presumably most of them are benign, right?
Well,
apparently,
yeah.
We're still
although
here.
I mean, there are all sorts
the
of
evidence is before you.
I mean, there are all sorts of diseases and sicknesses and illnesses just kind of crop up out of nowhere.
Well, I'm just so grateful to my lymphocytes. I just want to give you guys a big shout out.
Well done.
Good job, guys. Good job.
Keep it up.
Good job, guys.
So the deposition rates of viruses were 9 to 461 times greater than the rates for bacteria, even at those elevations.
Wow.
That is absolutely fascinating. I would never have guessed anything like that.
800 million per day.
I would have guessed like 20.
There was this
It's a veritable blanket of viruses.
There was this sort of iconoclastic ID attending back at Worcester State Hospital when I was a med student called Richard Glue. And every time he got a new crop of fellows and med students to come past him, he would give this lecture about how the world is covered in a fine fecal patina. Mm-hmm. And he would smile and giggle, and he had a little bow tie. And he's right. And like Don, you've just provided sort of empirical evidence of this.
That's right.
Because we're also covered with saliva.
Gross.
Wow, our immune systems they're doing a bang up job. So
all
cool.
right. Chris, what do you got for us?
Well, I wanted to talk about a trivial issue about the de novo origins of multicellularity and responsive predation.
Yeah, no, we were just talking about that.
It comes up all the time.
This is from the journal Scientific Reports, which is one of the Nature subjournals, and the lead author is Heron. And he was sort of curious about the origins of multicellular life on the planet, and we can stipulate that there's a lot of multicellular animals on the planet. I don't know if what the breakdown between unicellular and multicellular animals is, because there's a heck of a lot of bacteria that are unicellular, but clearly multicellularity is a very common outcome of evolution, and it has evolved many, many, many times because we have fungi, and we have kelp, and we have humans, we have insects, and we have birds. We have multicellularity has occurred over and over and over and over and over again. And so it's sort of obvious that this is something that just happens. And the reason it happens is that, one of the reasons we believe it happens is that little things get eaten by bigger things. And so if you can make yourself bigger, it makes it harder for the bigger things to eat you because you're now bigger than the things that were previously eating you. So multicellularity is probably driven in part by predation. And so he wanted to test this theory empirically, because we have fossil records for multicellular organisms, but the smaller the multicellular organisms get, the less we have a fossil record. So when we're talking about Volvox or something like that, or, we have no fossil record of that at all. So we don't really know what happened to the initial transition point between unicellular and multicellularity, because there is no fossil record for that whatsoever. So what they tried to do this is to study this experimentally using this sort of very simple model of a kind of an algae called Chlamydomonas reinhardtii, which is a common algae. I don't know what it does, but it's an algae that is a unicellular organism in ponds. And then there's also this creature that we're very fond of, that we know and love, called Paramecium. And Paramecium eat algae, unicellular algae. And so what they did is they set up an experiment where they grew a bunch of these Chlamydomonas guys, and they just let them do their thing without any interference. And they remained unicellular. They just grew and grew and grew and grew and continued to be unicellular sort of indefinitely. But when you put parameciums into the dish with them, they became multicellular.
Cool.
So cool.
Wow.
And they did it quickly. It was like within 100 generations, they became multicellular animals. Wow. And they did it in 3 different ways. So one of them, which was like the most rudimentary, is that they started to secrete this sort of gluey extracellular matrix, which kind of like stuck them together. So they became glued to each other. So it was like a very crude way of making a multicellular organism by basically creating this sort of like glue trap. That
basically just stapled them together.
Staple them together, right. And it not only captured the daughter algae that were budding off of the mother algae, but it would also capture free swimming algae that would get stuck in this. And so they would also benefit. And so it was polyclonal. It was lots of different sort of genetically unrelated algae glomming together. So that was one way they did this.
But did they eventually start acting as a unified organism?
I think they were on the transition here, but it made it hard for the parameciums to eat them because they were too big, right? And plus it was all gluey. But there was another way that they did this, which was, and the daughter cells, I should mention, would bud off as individual algae and would sort of swim away and like maybe form their own glue trap colonies elsewhere. The second strategy that these things did was to create true sort of uniclonal, genetically identical colonies where they would just stick to each other and become giant big globs of algae, which were too big for the parameciums to eat. But when they would reproduce, they would set off like individual cell budding cells so they can kind of like freely look for new habitats to live in. And then the third one, which was the most interesting of all, is that these things started to create multicellular daughter cells.
So true evolution.
So now they've created these big sort of glob colonies of algae, and they send off these daughter colonies, which are also big blob things that can't be eaten by the parameciums. Wow. And when you took away the parameciums, they wouldn't do this.
Wow.
And I was like, wow, it happened so fast.
Wow. Fascinating.
It was, I thought this was like, that is so cool. What a neat bit of science they did. So that's what I wanted to talk about.
Very cool. All right. Well, I will finish this up with taking us back to basics. So can either of you guys tell me the definition of epidemiology?
Oh, God. Upon the people.
No, that's the
etymologic definition.
Yeah. But what is the definition of epidemiology?
It's the study of populations, isn't it?
It's how to remove a pump handle.
It's a subdiscipline of psychiatry where we talk about people who are very vexed by living in a 2x2 square box.
That's an interesting. No, I was always taught that it was the study of the distribution and determinants of diseases in human populations.
Oh, okay.
That sounds
right. I was going to say that.
Yeah. That's what I was always heard.
Seeing as the three of us are technically epidemiologists, it's nice to know this at last.
I'm not. I'm definitely not.
It turns out there are other definitions, which I was not aware of until today when I was trying to get ready for a presentation that I have to give, because I looked up epidemiology on the Urban Dictionary. And there are two definitions in the Urban Dictionary for epidemiology.
Is one of them naughty?
No. So the first is medicine that deals with how disease starts and how it spreads out, as well as how to control said disease.
What?
As in, the doctor used epidemiology to cure the killer fart.
I don't think that's right.
I think that's way wrong.
Okay, well, let's try the second definition then, which is epidemiology. What happens when you don't get into med school the first time around? As in, I just got rejected from medical school. Oh, well, there's always epidemiology.
Oh, Matt.
Or public health.
Matt, are you still licking your wounds?
Which is a reminder that we do not always get to define ourselves, and others will do it for us. Okay.
Oh, funny. That's funny. You went to Bates College, right?
I did. Why?
Yeah. Mathematics, right? Didn't you study math or something? What did you study?
No, English literature. Why?
No way.
Yeah.
Yeah?
Oh, yeah.
Wow.
Yeah.
We had no idea you were that erudite.
Oh, I'm totally erudite. I am as erudite as you could get.
Is that how you know all about pop culture?
Especially having lived in England for 6 months.
That's exactly. So that is the end of our program.
Thankfully.
One quick note for you, to our listeners, which is that we are going to be taking a little bit of a summer hiatus because of my transition back to the States and the general malaise. No, malaise isn't the right word. What is it that we do in the summer in the U.S.? We become dormant. We go into summer hibernation.
Lassitude.
So, we will think about whether or not we're going to put out a best of episode or something like that, but we'll be away for just a little bit, but we will be back. And in the meantime, if you've got any feedback on this or any other episode, or you want to suggest a topic for us to take on, you can tweet us at @PopHealthyX, or you can tweet me at @ProfMattFox, or Chris at @ID.Gill, or Don at @DTheo1. And I still say Chris's, even though I don't think he's actually even on Twitter. But
I do have an account.
Is there, or you can find us on the Population Health Exchange website at www.pophealthex.org. We want to thank Leslie Talalian, Director of Lifelong Learning at the BU School of Public Health, for supporting the podcast, and Nick Guler for his tremendous sound and editing work. Thank you for joining us. We hope you enjoyed it, and we will be back as soon as we possibly can with our next episode.